Good morning, and thank you so much for joining us this morning. My name is Jessica McQuay from Philips Healthcare, and I'm very excited this morning to introduce two health systems that our Philips eICU has been partnering with for a few years now, Ascension Health and Dartmouth-Hitchcock Medical Center. They're each going to speak to you today about their objectives to transform access to and delivery of critical care throughout their health systems by way of acute telehealth. I will ask you to keep your questions until both health systems have presented, and then we'll have them join back together as a panel at the end of this dual session to answer your question. So without further delay, it's my pleasure to introduce Dr. Mira, Ilescu, Davine, and Levine, and Julie Mills from Ascension Health.
Thank you so much, Jessica. Good morning. We are very humbled and happy to be part of the presentation and part of Society of Critical Care Medicine presentation. We would like to share with you our story, and we promise we are not going to center our story around COVID. We'll try to actually use COVID as a context, not necessarily as a catalyst. Julie and I are actually a living proof of one of our mantras. We believe in dyad nurse physicians. We work together around the virtual thinking table. We work together in the Tele Icu, and as you can see, we present together. Our story starts more than 15 years ago. In 2005, we had a modest beginning. A couple of hospitals, 6 of them, 1 EMR, a few physicians and nurses very dedicated to a new concept that we all know was not embraced from the get-go. As time passed, we were able to forge partnership with more hospitals, more bedside nurses and physicians, and slowly build the concept. I believe the key word here is slowly. It took us time to convince that virtual health has a role at the table. We're not the eye in the sky. We are your partner at the bedside. When you are tired, we are there. When you are overwhelmed by volumes or acuity, we can help. We're also very kind reminders. We like to imagine ourselves as being a little bit like the nagging mother that reminds the bedside that the sepsis bundle needs to be completed, that the patient needs to be screened for sepsis, that vein liberation trial needs to occur. Our partnership grew and grew over years, and we had, I think, one hiatus of a few years when during daytime we did not have our famous dyad, physician nurse. Only the nurses were actually covering 7 a.m. and 7 p.m. And that bred a lot of frustration. Our Tele Icu nurses asked for the Tele Icu physicians to come back. As we were able to grow, we were able to turn into a 24/7 model. And I believe that consistency and partnership 24/7 is the key to success. As of 2022, we realized that the same way medical world is reinventing itself, we have to add different concepts and different components. As I mentioned, COVID was not the only reason why Tele Icu and virtual health begin to have a different level of acceptance from the bedside. COVID has been a catalyst, forcing us to get out of our own shell, forcing us to think outside the box. In reality, as Tele Icu nurses and Tele Icu physicians, we're so clingy to the fixed model. We're so comfortable being able to watch patients within the ICU geography. I'd like to give COVID credit for forcing us to think and create concepts such as critical care sans frontières. Critical care can be taken care of, can be managed, can be practiced anywhere where acuity exists. So this war front that COVID created allowed us to build and allow us to expand. The reality of today. It's not an easy reality, and I think we all know that. We do have a practitioner shortage, both when it comes to critical care nurses and critical care physicians. Everybody's fatigued, everybody's tired. The last 2.5 years were very busy with high acuity, with a lot of death and a lot of long hours. We also started to notice that outcomes may not be as stellar as they were before. And we started to look at hospital-acquired infections as a consequence of high acuity and having to place lines. And CRRT dialysis catheters on all our patients. The harm exists. What can we do to reverse it? What can we do to actually improve quality, outcomes, zero harm, and also redeem our finances? Because in all fairness, the last 2.5 years affected the finances. What do we do today? Again, we have a couple of keywords. The real-time approach. We believe in real-time 24/7 intervention. Extubate the patient at 2:00 in the morning. Transfer the patient when the care is complete and it's safe to move the patient to a lower level of care. It's not a 9 to 5 approach. It's a 24/7 coverage, 24/7 partnership. The diet between a physician and nurse, I think it's centerpiece for our practice. Physicians cannot function without nurses, and vice versa is also the reality. I'm basking in the outcomes and the partnership that the last few years allow us to build. I see the relationship between nurses and physicians as the key in order to improve patient care. We need to add another dimension. We need to understand that the bedside, being tired, they need our efforts, our eyes and ears, and our partnership. So the diet is within Tele Icu, the diet is between Tele Icu and the bedside. We need to share resources. When we have nurses that are triple or quadruple at the bedside, or physicians that cannot be on call 24/7, Tele Icu can supplement that lack of bedside workforce. And we are there to do that. And we are actually a living example that this can be a success. Hence, we build up this concept, critical care without borders, critical care sans frontières. And Julie is going to actually take the next step in sharing with all of us how technology can be the conduit between clinical thinking and taking care of patients anywhere.
Thank you. So we really look at the technology as a transformational tool. It empowers us to improve patient outcomes. We really can work towards achieving zero harm. Using this technology as a transformational tool, we optimize the transition of care. We reduce length of stay, and we avoid excess days in our ICU. And as Dr. Ilescu mentioned, it allows us to step outside the ICU geography to recognize and prevent patient deterioration. And this hybrid model really allows the physicians and the nurses to practice at the top of their license, creating a safe environment and really adding that joy factor to the team, both virtual and bedside. As we looked across the last couple of years and really looked at our trajectory, during the height of the pandemic, we saw a significant increase in our physician and nursing interventions. This was not only due to the patient acuity and the number of patients that we saw, but also from the increased support that was needed for our bedside partners. Our physician interventions alone tripled from an average of 800 a month to over 2,600 a month. And nursing interventions and support have continued to increase over the last couple of years. And we're going to talk a little bit more about that partnership as we move forward into the next couple of slides.
We brought to the arena a couple of key concepts: zero harm, transition of care, transformation tool, diet, partnership, bedside Tele Icu. How can we achieve that? And I know that initially we talked about diet, but as we evolved, we realized that we need to partner with another key component of the medical world, pharmacy. Telepharmacy, we believe, is the next level for Ascension, Illinois, in terms of partnership. We need a pharmacist with us, at least at night, in order to evaluate drips, educate nurses, support physicians, and make sure that medication error is zero, part of the Zero Harm Initiative. We like to structure our approach and partnership in pods, with the understanding that we should be able to advance from critical care towards less acute care by having telehospitalists, telemetry nurses, ED nurses joining and being part of the team. As we mentioned, the critical care evaluation and care happens everywhere, in the ICU, in ED, medical surgical floor, telemetry, overflow areas where we can actually reach with the technology be able to visualize the patient, assess the patient with the bedside team, and make decisions together as a good structure. The telehospitalist pod will be a great addition to Tele ICU pod in the sense that so many situations on the floor can be prevented. We can recognize and we can prevent patient deterioration. And you don't always need a critical care physician or a critical care nurse to be at the forefront for that. A telehospitalist partnering with a teleintensivist can take care of patients and prevent catastrophic situations happening on the floor. And if the patients deteriorate, it's going to be a smooth transition from telemetry, med-surg to the ICU with a wonderful virtual or in-person handoff between the telehospitalist and teleintensivist. The care can continue outside with hospital at home, as well as remote patient monitoring and home health. And again, all those pods can have a boots on ground component as well as a virtual component. We are looking forward to expand, and currently within Ascension, Illinois, we do have the Tele ICU pod, the Tele Home Health pod, and we are going towards a hospital at home, remote patient monitoring, and a telehospitalist program.
As you can see from the previous slide, we wholeheartedly believe in a multidisciplinary team approach. We partner with our bedside colleagues in patient handoff, in multidisciplinary rounds, in their local critical care meetings to ensure the highest level of quality care for our patients. The Ascension Tele ICU leadership co-leads our system critical care committee that really focuses on standardizing best practices and protocols for our ICU patients and patient population. The multidisciplinary approach is also utilized within our Tele ICU. As you saw with our pod approach, we have a strong collaboration between our physicians, our nurses, and pharmacy as well.
Ascension as an organization has a very strong initiative, Recognize and Rescue. So what did Julie and I do? We added the E component, E-recognize and E-rescue. Our thinking has been for decades around critical care and medicine or surgical patients. We are thinking ARDS, septic shock, heart attack. This is what we associate with the concept of critical care. And obviously, E-recognize and E-rescue is extremely important. We want to have eyes on patients on the floor, telemetry and med-surg, recognize changing status, prevent code blues on the floor, and call the RRTs, code sepsis, code heart, code stroke accordingly based on the clinical status. But we realize that we are missing a significant portion of our patients, behavioral health patients. Those patients have high level of acuity, and they actually follow a critical pathway, a behavioral health critical pathway. So we would like to actually partner with our behavioral health physicians and create a string of de-escalation, early recognition, and early rescue for patients with behavioral health conditions. We always thought that the rapid response that we call on med-surg or telemetry floors has a great equivalent in code BERT. And again, audiovisual tools can help evaluate those patients, and behavioral health specialists can early de-escalate, being able to prevent a code stroke, which is the equivalent of code blue. The manpower that needs to be involved in a code strong, the medication, the pharmacy, the intelligence, the protocols, everything is very time consuming, and it's pretty much the equivalent of a code blue for internal medicine and surgical patients.
Moving on from there, you've heard us mention the hybrid model a couple of times. We really believe that this is the best practice in caring for our patients. We have done a lot of work within our ICUs, partnering with our bedside teams to help them round visualization of patients, doing device rounding for catheters and central lines, looking at skin and helping our bedside partners do their skin rounds and documentation. We're sharing resources. We're helping to coach and mentor all of the new nurses that are coming into our ICU. We see with the the staffing crisis that's out there, that most of the nurses now coming into the ICU are brand new. They're either new graduate nurses or they're relatively new nurses coming in from a med-surg tele. There's a lot of mentoring and coaching that needs to happen within that ICU arena. We can help them verify medications and co-sign medications, doing the procedural timeout and documentation, and making phone calls to help our bedside partners when they're doing organ referrals. That's all within the ICU, and that is just the beginning. We know that there is a lot of opportunity to really continue to partner and support the bedside as they struggle through this nursing shortage. In the non-ICU areas, we talked about eRecognize and eRescue. We really have a focus on early identification through an early warning system that we centrally monitor, and we support our med-surg tele nurses, and we coach and mentor there as well. We also are involved in Code Blue outside of the ICU, rapid response, Code Sepsis, and we do all of that virtually through devices and keep our ICU nurses in the ICU and helping to support those patients. So again, supporting the staffing as well. With education, we know that there's a lot that we can do. Again, I mentioned mentoring and coaching, peer-to-peer support. New nurses coming off orientation need a lot of help and a lot of assistance still. So developing a mentorship program that we are going to support the nurses as they come off orientation, giving them a buddy, a resource, somebody they can reach out to with any questions, and check in throughout their shift, making sure that their critical thinking is there and that the plan of care for the day is appropriate for those patients. So we hope that with all of this, we will be continuing to support our bedside colleagues and our patients ultimately.
We use the word transformation from the get-go as being one of our center concepts. We realize that everything that we presented needs to be measured in outcomes. And the outcomes are going to involve quality metrics, safety metrics, transition of care metrics, and financial metrics, being the reality of today. In terms of quality metrics, we centered our interest in zero harm, as well as CMS and Leapfrog grades. Our partners aim for Leapfrog A. The Tele Icu present allows them to actually effectuate changes in a lot of the metrics that Leapfrog measures. CPO is only one of them. We are pretty much involved in hospital-acquired infection prevention. As Julie mentioned, we do device rounds with the bedside nurses. We are also very much involved in best practices with DVT prophylaxis. Our numbers are close to 100%. We do aim to communicate and be the 24/7 communicators present at the bedside. We always have end-of-life conversations, communication about medication, communication about the clinical status, and that has been recognized not only in data and numbers, but also in notes and appreciation and comments from the bedside nurses and families. ICU and hospital mortality can be affected by everything that Tele Icu does 24/7, and obviously we're pretty much involved in vent liberation trials, Wake Up and Breathe. The length of stay, despite COVID and the craziness of COVID, has not been that affected because, again, we were there to partner with the bedside and de-escalate, downgrade, and help move the patient when the bed on the floor was available and the patient was ready to be downgraded. The zero harm concept has been very dear to our hearts, and actually we work with our Ascension partners to develop zero harm dashboards where both bedside and Tele Icu can affect change and improve outcomes. The transition of care, we actually use a great tool, the discharge readiness score. We educated the bedside nurses and case managers as well as physicians, and the DRS is becoming a tool that the bedside is using on a regular basis. They use it during daytime, during the multidisciplinary rounds, and as let me get ready for tonight and for the night shift, and have a list of patients that can optimally be transferred. The Tele Icu would be actually the body of the bedside, looking at the patient, evaluating the patient, and validating that the transfer is actually still available and safe. In terms of volumes, we all understand that medicine has a business aspect, and Tele Icu can be a fantastic partner in stabilizing patients, conserving volumes, especially in critical access hospitals. And we have some very nice examples in terms of that. Finance, sharing resources through a nursing team program, tele-education, tele-mentoring, physician coverings, Tele Icu physician covering at night. That means eliminating the need for bedside hospitalists or bedside intensivists. That adds to the financial positive balance and creates great financial outcomes without doing anything but good to the quality outcomes. We put people at the end, but not because we believe they're the last on the totem pole. We think patient and patient caregiver-centered approach leads to success. We think that by having a hybrid model between virtual and bedside, we allow the bedside to rest. Physicians go home sleeping well, knowing that somebody else will take care of their patients, and in the morning they will find everybody tucked in and stable. And if not, we'll communicate. The bedside nurses know that they have always a support in Tele Icu nurses and Tele Icu physician, so they don't start their shift with a high heart rate and with high level of anxiety. That actually created a lot of comfort, joy factor, as Julie mentioned, and fantastic partnership. This is our story in a nutshell. Definitely more details are available, but we would like to pass the baton to our friends and partners, Dartmouth Group. Thank you.
Thank you so much, Julie and Dr. Ilescu Levine for sharing such an impressive journey, and also, the rationale and the why behind how you've stood up your tele-critical care program, and you see it continuing to grow and improve. We're going to pivot now and hear from Lillian Powell and Dr. Stephen Sturgeoner at Dartmouth-Hitchcock Medical Center, another very innovative acute telehealth team who, just since going live in 2019, has seen some great outcomes and gained some powerful best practices. Dr. Sturgeoner and Lily.
Thank you so much. Steve and I are going to kind of hand things off slide to slide, and we'll each sort of chime in where the other one has missed something important. But I want to first echo what Mira and Jess mentioned, in that COVID really for us did serve as an opportunity to rethink and contextualize our approach to acute telehealth more broadly. And for us, it really did serve as a strong and powerful motivator to think about things differently, and forced our region really to think about how we handle patients with critical care needs. So again, hopefully we won't have to dwell on it too much, but it really was a big part of our development over these past couple of years, and want to make sure that we acknowledge that at the outset. So first, a little bit about who we are in our health system. So Dartmouth Health is a health system with an academic medical center, Dartmouth-Hitchcock, and 4 other hospital members, a community hospital and 3 critical access hospitals, plus a visiting nurse association. We are one of the most rural academic medical centers in the United States, and we serve a population of 2 million. So much smaller than Ascension, and we really kind of sit right in the middle of a more semi-urban geography that serves a really, really wide and very rural region itself. Steve, I'll give you the opportunity to weigh in here and say anything that you want to about our system and our development over time. Yeah, you've been with the organization for a lot longer than I have.
We just keep going. I think you're doing perfect.
Great. So a quick review of what our Tele Icu program entails. So similar to the Ascension model, we leverage a 24/7 service with a physician and nurse dyad. We think that is an incredibly powerful grouping, and both groups really do need each other to make an impact at the bedside. We use the Philips platform to drive a lot of our interventions, the predictive analytics and some of the scores that help us to prioritize interventions at the bedside. We really focus on being able to help support the bedside in that proactive care to help prevent future deterioration, and being there reactively when the bedside has a question or needs assistance. That responsive support became really critical as we dealt with a variety of new pieces of information, new practices during the pandemic, and has served as really a strong model for how we support our region and our bedsides in a very rapidly changing critical care space. Our Tele Icu program allows our regional hospitals to avoid unnecessary transfers to our academic medical center, which was critical during a period when our capacity was severely diminished during the pandemic. It helps us to improve patient outcomes before the pandemic, and throughout the pandemic, we've been able to maintain really low ICU length of stay and address, stronger event management practices. We also use our program to increase access to specialists within the critical care space across the region. And one last thing to mention there, with our Tele Icu program, we support a variety of different models. In our academic medical center, we have very experienced intensivists and nurses caring for patients at the bedside, but we support a variety of models in our regional hospitals, including models where they rely on a hospitalist team to care for patients, and models where they use associate providers to care for patients during the evening hours. So a lot of variety in our Tele Icu program, which has given us a lot of opportunities to provide really robust support to the region. Just a quick image, because I think it's always really helpful to see where people come from. This is a picture of our Tele Icu hub. One thing that you can't see is right across from this hub, we have our Tele Ed hub. So we won't spend a ton of time on it today, but our Tele Icu program is one of a variety of telehealth programs that Dartmouth-Hitchcock has decided to invest in. You'll see each of them here on the bottom of the slide in our little banner. The Tele Ed Hub is also a 24/7 service that supports hospitals throughout our region with immediate access to experienced board-certified ED docs, as well as experienced ED nurses to help our smaller hospitals manage those real-time emergent situations. Quick picture here of one of our ICU rooms. You can see a little bit of our technology here posted up on the ceiling. And this is how we use the technology to engage with the bedside. One other thing that I think is important to look at is just to get a sense of the scale of our program and the growth of our program since we started it in 2019 is the number of unit stays that we've been involved in. So over time, we've experienced some considerable growth in the number of the unit stays that we touch, so to speak. We're still fairly small, but we have a lot of touch points throughout the region, not just through our Tele Icu program, but through our collaboration with the other telehealth services like Tele Ed, which allows us to reach further into our regional emergency departments. I thought it was worth acknowledging the situation that compelled us to innovate during this period. And Steve, I'll toss it over to you because you really were instrumental in our region's approach to COVID during the early days. And I thought you might be able to better contextualize what this felt like for us as we saw rising acuity and decreased ICU capacity.
Yep, thanks, and great job with the background. That was a perfect intro. This slide, and we will just chat about COVID for just a couple of minutes, just as a backdrop, but get to what we're going forward with. You know, it's interesting to look at this graph on the left and notice that we actually had a very underwhelming surge in the beginning of the whole pandemic in 2020, and that really was okay with us in some ways because we really were in a position where we could learn from others that were really in the middle of this. And we essentially did a slow motion disaster management process with many of the hospitals in our area. And it was nice in some ways to have that time to do it. We did it with our formal partners. We have 4 other hospitals that we had up and running at that time on our system that's varied from a very rural location up above Mount Washington, where it snows a lot in New Hampshire, to a place over near Burlington, Vermont, and 2 down south of us. We spend a lot of time, and I'll chat more about this, about sort of working on the basics of protocols and processes and education to get people up and running, working on what their supply chain had in mind and what their capabilities would be and what they weren't. We also expanded outside of our ICU geography, as you heard in the last conversation. We, through the the convenience of the public health emergencies declared by the state of Vermont and New Hampshire made it a lot easier to license people at all kinds of places really fast. We basically offered our services beyond our formal contracted Tele Icu program to any critical access hospital that wanted to have access to our hub 24/7. And we did something similar to what you heard, where we used a cart-based model to essentially consult on patients who were stuck and couldn't get to an academic medical center when we hit these bigger peaks, or simply just, a team that hadn't really seen an inpatient COVID patient yet and just had some basic questions about what to do and wanted to run our checklist. And we had built our own internal document about what our standard of practice was for COVID patients from moderately ill to ECMO. And so we were able to apply those to any patient that needed us in the region. And then inside our hospital, we also expanded outside of our geography and stood up a support to step-down patients on the hospital service, which were, at least at some phases of the pandemic, seemed to be a high-risk group. I think we understand more about them now than we did, but we wanted to really have some good eyes on those patients and be a partner in a similar fashion to what was described before to our bedside colleagues when they were exhausted, going in and out of rooms with all the PPE problems and everything that we all remember. So those are examples of what we did. I think the right side of this slide is important as well, because what really happened to us in rural northern New England was we reached a real close to crisis lack of access to academic medical centers or tertiary care ICUs in our region, and I'll expand that even into the Northeast. We were getting ECMO consults from outside of our region. We were getting 3 or 4 ECMO consults a day when we hit that large peak last fall. We had a peak that started at some of our rural areas, interestingly, earlier than the winter, and we had quite a shoulder that you can see in September. So this really went on for long periods of time, and we actually went to having an extra nurse and an extra physician during the busiest times of the day working in our hub as well. So that's sort of our background there. Next slide. Just as a little bit more about this access crisis, it was just like what everybody else experienced at whatever point of the pandemic it hit you, where your staffing was a problem. You had people calling out and sick. You might have had people retiring. It was hard to move patients around, and it was a real problem for us. And as this Concord Monitor quote describes, in December, it really was quite bad up here. Next slide. We had the fortune in March of 2020 of having the first acutely and critically ill patient in the state of Vermont, which showed up at one of the wired beds that we had. It was a 46-year-old male. He had single organ failure. He had terrible ARDS. We couldn't figure out how to move him. It was the middle of a snowy period. The transport teams didn't know how to do PPE for 2.5 or 3 hours in the back of an ambulance. All the problems that faced all of us at the beginning. We simply just decided to keep this patient where he was. And we talked a team of really good and dedicated nurses and physicians and respiratory therapists through proning and paralyzing and, careful fluid management, all the things that we need to do. And it was really their first time ever really doing it with an ARDS patient that they weren't trying to get out of their hospital to somewhere else. And so they bared down, they really stepped up and did an incredible job. And this guy walked out of the hospital and went back home without even a rehab stay. It was quite a success. Next slide. Just gives a slide of how extensive this guy's disease was and where we were when he first showed up. If we go to the next slide, really for us, connecting back to that slide that showed the lack of access to tertiary care ICU beds that was happening in our Twin State area, and honestly in all of northern New England back in that time. Really what we look back at is that our Tele Icu program basically gave our tertiary care hospital with 60 ICU beds for adults a 25 to 30% bump in access capacity to experts that could really walk people through any number of things. And as we all know, access to everything was a problem during these time periods. And it might have been a cardiac patient or it might have been a neuro patient. It wasn't always COVID, but we were able to sort out who needed to come and who needed to go where, and make some timing and make some good decisions with families, and decide who wanted to stay in their community and get good care there, but not necessarily go to the next step. And it was really an incredible success story. We had several patients that came out of our ICUs that we were covering that we got to our institution for timely VV ECMO, and we had several good survivors by not missing that sweet spot of the window when they needed to come here, because we were taking care of them with that bedside team. Next slide. Just to go back to, the disaster management part that I talked about over time, I really think that, using the old Donna Beedian, we really worked on structure and process with our teams when we had the time back after we came out of that first small bump of a wave in the beginning of the pandemic. We were lucky up here to have the time to do focused education, really coordinate with these teams and say, how's your blood bank situation? How's your your supply chain for, your ventilators, and what would we do if you ran out of ventilators? And we figured out contingency plans with each of them to sort out how we would manage things. And really was impressive to see these small hospitals in their communities really step up and just say, we are going to roll up our sleeves and deal with this. It was really an incredible process. We did a lot of one-on-one mentoring, both, if we needed to do it before the patient actually showed up, we did that, but we also certainly did mentoring one-on-one as people were going through, and doing many of the beyond the basics proactive components that I think really helps Tele Icu succeed, that you heard about in the last talk, of just really trying to step forward and be that gentle reminder about, daily prevention, but also working through, it's really critical when you're in a place that doesn't have 24/7 access to a fellow or an attending that can come in and do their central lines or their arterial lines, to plan all that stuff ahead, get the feeding tube in during daylight hours when it's safe. And so that way we can, get these patients through successfully and have them get essentially very similar care that they would at another place. On the next slide, just a few specifics that, aren't big shockers, but we really did spend a lot of time on modernizing, and we honestly use Society of Critical Care Medicine materials very heavily. So thanks to them for having those available. On the modern approach to sedation and analgesia, and then paralytics, proning, ARDS, and with even a couple of these places we started doing, they've got an Arctic sun or some of their machine to use targeted temperature management, and we stood that up as well, because it was really an effective strategy for us to, we didn't have perfect access to our cardiology and cath lab services at that time, and if we found patients that didn't need to urgently come up to be near a cardiac cath lab, we would keep them at some of these facilities, but obviously watch them for any changes and reprioritize them as we needed. So I think that's the extent. Actually, one more slide, sorry, on coordination. Lillian talked about the fact that we had a tele-ED, and we had several successful adventures with them where we would be either walking over to their hub, or sometimes they would come over to our hub, and we would sort out how we would work on a patient that had showed up at a facility and deal with how to triage them. And that work continues. Our regional consult network work continues as we exit the pandemic. We're going through and really trying to keep that shored up, because I think it really is an important service that we can offer to communities in our area. We do have a fairly well organized transfer center that uses our Tele Icu team to help make triage decisions about who should go to what facility and what kind of care they need right now. Hard work. There's so many variable patients that show up, and it's amazing to see the patients that show up at some of these facilities that need really detailed, sophisticated care in a timely manner. And it's hard to protocolize that, but but working together, we really have had great success reducing the number of patients we bring that might be sort of in a feudal care situation, but enhancing our ability to bring patients in quickly when they really need to. And then redirects is another success that I mentioned a little bit with the target temperature management. We really have been able to hold off on patients that we don't think need to come to our adult critical care beds at our tertiary hospital right this second, and yet we can keep a close eye on them with that team. And that has been a huge trust building process that really has worked for both sides. And I think the next slide is back to you, Lily.
Yeah, I'll breeze through these quickly. The mentoring was another important part of being able to grow our capacity for critical care in our region, especially as our institution had to move towards a team nursing model. To build that critical care capacity, it was critical to have access to experienced critical care resources. We were able to spread those resources more fully across our ICUs using our Tele Icu equipment and programs. Steve mentioned the step-down monitoring and COVID coaching for our sites, but just want to nod to the fact that mentoring is critical when we think about trying to increase critical care capacity. Additionally, some of this task sharing work that we really, hadn't done a ton of before COVID and started doing a lot of during COVID was dual sign off on meds, assisting with some documentation at the bedside when, a nurse really needed some help, managing communication for the team when they were stuck in the room, helping conduct family visits, managing visual rounds when PPE really needs to be conserved. And I think all of these things we've talked about have served to support our evolution here. As we kind of think about where we want to go next, we think that there is more work we can do to extend critical care capacity in our region through our Tele Icu program and other acute telehealth programs, supporting new regional ICU capacities through our education and mentoring, whether that's helping some of our sites who realized they could do more during the pandemic to adopt new services like CDVH, helping to support them through that kind of critical care capacity growth process is going to be big for us. Also looking internally to our own academic medical center and becoming a part of developing programs to become a part of the workflow and change the nature of our work in the critical care setting to make a virtual resource an important offloader of work so that the ICU nurses can provide more direct care to their patients without having to worry about some of those administrative coordination tasks or documentation tasks. So this is something that we're actively piloting right now, based on our experience doing some of these tasks for the bedside during the pandemic. In addition, growing beyond the ICU, we also have a really robust emergency rescue program that we call Life Safety at DH. We are looking to use what we've learned about virtual care to extend the reach of those really experienced critical care response resources to a new patient pavilion that we're building at DH and to our legacy pavilion settings. So as we look into the future where there are more nurses with less experience, we have to be really smart and really thoughtful about how we can expand access to the knowledge base that our more experienced nurses have developed over a long time. Using video tools and some of the electronic tools that we've come to know through our Tele Icu program, we will be increasing the number of instances where a bedside nurse can reach out and ask for help early, and increasing the amount of information that our life safety nurses have to reach out and prevent deterioration before it happens. So, we have to be really thoughtful and scrappy with our investments because we're small and our region needs so much from our centrally located tertiary care center. It's really incumbent on us to take that next step and invest in these new programs that have the potential to help our region manage ongoing capacity crises, both on the nursing front and on the physician front. So I'm happy to sort of pause there. Jess, I know we were going to move to a panel Q&A. Helpful for me to stop sharing and
yeah, I think if everyone could just come on camera, I think that'd be great. Dr. Sturgeoner and Lillian, thank you so much, especially your real life scenarios and the examples of outcomes you offered and the lessons you've learned sort of in real time as you've gone. It's been very valuable to our audience, I'm sure, and as was Ascension's presentation earlier. As Lillian said, we're going to move into a panel discussion now. And so, audience, if you want to put any questions at all that you have into the chat, we'll get those answered live for you. While we're waiting for that, I'm going to start with one. Ascension and Dartmouth, both of you have been notably creative in putting together an array of clinical services that your tele-critical care teams offer, as well as mentorship, of course. How key is that to the success of standing up and maintaining your acute telehealth program for the long haul? I'll point to Dartmouth first, and then we'll go to Ascension to answer that.
Yeah, I mean, I'll just say that I think it's extremely important to be able to adapt. I mean, I think healthcare is changing extremely rapidly over time. The things that are going on right now that we never would have thought would be going on, 3 years ago before this pandemic is just amazing. The staffing challenges, the supply chain challenges, the way patients are presenting with more comorbidities than ever. I think we've had to be adaptive. I think you heard from our colleagues here that it's a slow process. You can only go so fast. So that is the hard part, is that you can only pace your change to the extent that your teams can keep up with it and handle it. But I think it was really amazing to see, during the pandemic, and now as we're getting out of it, people, I think, do realize that they can step up and really get a new process going very quickly if they really get dedicated to it. But it takes that team's energy. Those are my thoughts.
Absolutely. Dr. Ilescu?
If I can piggyback on Steve's comment, the slowness of the growth is there, but we also believe in change from transformational standpoint. So transformational change is very important. And we actually had some fun stories. 2:00 in the morning, we get a phone call that the RRT critical care nurse needs to stay in the ICU and take care of the patients because they had shortages at the bedside. It's nothing that you can argue or prevent. So what did we do? We literally assigned a Tele Icu nurse that was taking care of that ICU to become the RRT critical care nurse. And with the help of audiovisual and Philips platform, we are able to visualize and take care of the patients on the floor. And we had actually promptly 2 RRTs. And our Tele Icu physician, who's already part of the medical staff at that specific hospital, was able to help and partner with the bedside nurse, the Tele Icu nurse, and the hospitalist. And the reality is that we do have a lot of nurses that are coming out of the education pipeline, and the same goes with physicians. When I was at the bedside full time, we had hospitalists that were doing critical care procedures without any effort. Those days, we don't see that all the time. So literally, we have to be there to help them put a central line or decide about intubation, and we love doing that. But it takes a lot of acrobatics.
Yeah. A couple questions from the chat. Which Tele ICU outcomes have been most compelling to your health system leadership?
I would say mortality.
Go ahead.
I would say mortality. That's ICU and sepsis related mortality, length of stay, and the fact that we're able to maintain and elevate leapfrog and CMS grades. And again, we are very intentional in our critical care presentations for quality data. We have dedicated dashboards for leapfrog and CMS, literally opening the discussion on how can we partner, how can we support you, how can we help you avoid hospital-acquired infections. We actually partner with a new institution, and we realized their dashboard was a jungle, more or less. So we work with them as a team, and we ended up having a very nice zero harm dashboard that we start to effectuate in real time and do huddle every time a harm occurs. And it's a partnership between the Tele ICU nurse physician and the bedside team. And it works nicely, and it builds trust.
Yeah, mortality and length of stay are really important for our health system too. One of the things that I think is a little unique is that our smaller hospitals with smaller ICUs really are important to our health system as extensions of our critical care resources. So we have gotten a lot of traction in showing growth in acuity and growth in patients that are cared for at some of these smaller hospitals. that has, of course, value to those hospitals that are not a part of our system and their leadership team as they're looking to care for more critically ill patients at a higher level, because simply our academic medical center cannot handle the critical care demand that we've experienced in the region all the time. And it's best for patients to stay close to home when they can. So that's big for us to try to increase the level of care that patients can receive locally. It does great things for everybody, our health system and hospitals that are not a part of our health system but are in our region. Steve, what else do you think?
I think the other ones that we're gaining ground with, and they're not necessarily in the hard green dollars that the CFO might notice, but I think we're getting a lot of traction with. Here's an example: our Tele Icu physicians do all of the 600 to 800 transfer center phone calls a year for our medical ICU. If you multiply that number by about 20 to 30 minutes, which is what they all take, and you got to have someone that can support your residents and fellows on those calls and supervise that, and you've got to have someone that can keep these calls moving and make the right decisions. It's a huge benefit to our MICU team that they don't get disrupted for that amount of hours a year. And they really appreciate that. And that was a huge attractor to them to be involved in the program. And we built off of that. But that was the first good idea we had with them. And I think we're now doing that with a lot of our nursing colleagues. We are spending a lot of time on what tasks can we take off the plate of these overworked bedside nurses, particularly as you heard before, where it's a high intensity staffing day or not enough nurses in the unit that day. What can we do to take that off the plate? And so it's again an FTE sort of relief, if you will, but that's been a huge benefit for us to really, those stories trickle right up to the top of our organization when people hear those things.
Yeah. Another interesting question from the chat, and I heard you, Lillian, I think speak to a little bit of baseline data, but the question was, what metrics do you use to validate your assumption that tele ICU interventions actually improve outcomes? So I guess, as you're standing up your program, is it a practice to have some baseline data available to actually show the value since you started and continued your program?
Yeah, absolutely. I think length of stay is a big one. Mortality rates, those things are usually available at baseline. So, they can serve a strong foundation from which you can compare your efforts and see how effective they've been. We also, I think some of our hospitals too had tracked vent days before we brought them on with Tele Icu program. And then, measures of illness. So some had CMI available for their patient population. So we can look at all of those things and understand, are we impacting length of stay? Are we seeing any changes in the acuity of patients cared for? And are we having a positive impact on mortality? So I think all of those are fairly robust and straightforward to track, which makes it pretty straightforward to see whether or not you're making a difference.
And if I could just add, I think it's really important. We always, when we bring a new hospital online, we always ask them the question, what are your goals with this program? Right. Some of them aren't necessarily as focused on mortality. If they get it, that's great. But they several of the ones we work with we want to reinvigorate our ICU and have a program that attracts nurses and physicians to want to work here, because people like doing this work, but they don't like doing it at a low volume that it scares them. So getting their volume up a little bit was really the big goal. And so, we obviously can figure that out and measure it. It is hard at small hospitals. Sometimes they don't have a big data flow like you have at a big center. But you can sort it out. I mean, we had in particular one facility where their ICU volumes had trickled down to fairly low back in the 2015 range. We obviously didn't cause all this, but worked with that facility to improve their blood bank, improve their, that they get some central lines back in the kits and all, in the carts and all those basics. And we grew their volume. We improved their mortality, and we knew that we did it because they had baseline data, and we dropped their length of stay dramatically, and they were thrilled. So that it's definitely those basics can really work. But in other organizations, it can be that they really want their quality data to improve, and if you have some baseline, if you focus on that reliably around a 24/7 period, you can clearly make an impact on it.
Julie, I know that you were going to speak. I know that
Yeah.
you're very, very big on data. So I wanted to see if you had anything to add.
Yeah, a couple of things. I think to piggyback on what they said, I think number one, we do start with a questionnaire for any new hospitals that we bring up, and that kind of gives us their goals, but also their baseline data, so we can kind of start from there. In addition to some of the other baseline data that Lily already mentioned, sepsis was another big focus for us. So we definitely had our baseline data, and we also look at baseline for any of the new hospitals that come on, because we have such a strong sepsis program, and we've definitely seen great improvement over the years. And our most recent addition for our hospital, we've already seen an improvement over the last couple of months, and they're a fairly new program, and we've seen a great improvement in their sepsis mortality already. So I think that's another key component.
Great. There was another question in the chat that I thought was kind of interesting. It said, how does one get involved? And I wanted to ask Dartmouth, just because you're a younger program, if you're an intensivist or a critical care nurse that's interested in tele ICU, and your health system, you don't know if they have a tele ICU program, or you're interested in kind of getting a business case together, what are those steps and what does that look like?
Well, I mean, the honest answer is that, I used to run all the ICUs at Dartmouth back in the 2000s, and I proposed doing a tele ICU program in 2007. We got into it in 2015. So it can take a long period of time for an organization to view this as a priority when there's so many other priorities. I think that's just a reality of the situation. I think times are very different now, and I think the pressure to do this is probably a lot higher with the shortages of staff and the demands for more and more beds to be managed. As we're talking about, you got to manage your beds 24/7. You just can't leave it and shut off the lights at night anymore with any of these services. They've got to keep flowing, and decimal places of length of stay in big organizations are really important to improve and do it correctly. So how to get involved? I think if you want to get interested in this and work on it, what we did at Dartmouth was we actually contracted out 4 or 5 physicians. We worked for another organization. We worked for Vera in South Dakota. They needed some help with staffing, and it was an incredible experience. We learned an enormous amount from them. We figured out how we wanted to run our program and had a smooth transition into a new program when the time came. But that was really how we convinced ourselves that we wanted to get into this without taking the big jump initially. So that's one idea.
Just for us, I think data is the greatest equalizer. We are convincing our potential partners just by sharing the data and the experience. And I think the flexibility, and we are not only anecdotal in the flexibility stories, but the data reflects growth that literally happened overnight, or programs that we implemented during Thanksgiving and they spread like wildfire. So I think those stories and the data itself is the catalyst for new partnerships. And again, I think it's very important to listen to the potential partner, because as Steve was mentioning, you want to hear their story and their needs. Majority of the time, we actually hear managing the volume, because again, our hospitals, the current hospitals, are not critical access hospitals. We have only one. So managing the volumes is an issue. And how can you reach out to patients that are crashing outside the ICU? For us, that has been the challenge. But again, we are continuing to reinvent the program and adapt the program to the needs of our potential partners.
Fantastic. One other question from the chat: have either of your health systems considered pediatric ICU involved with your tele ICU?
Yes, in one word, but it's hard. It's very hard. We actually would like to have ED pediatric specialists if possible. That's the major need that we have within the system.
Yeah, we don't have any direct involvement with our PICU today, but we do have a tele-ICN program as part of our connected care programs, where we provide access to neonatologists in emergency room settings labor and delivery units in our region have really kind of cratered in recent years. Lots of hospitals have had to close them. So it's not uncommon for an emergency department to be in a situation where they are, in a high risk delivery place that they do not want to be. So then they have immediate on-call access to our neonatologists to assist. So we've gone that route in our EDs, but we haven't yet gone the route of working with or involving our pediatric ICU.
Gotcha. I think we've addressed all the questions in the chat. We have a couple minutes left. I'll add one more. Do you think, we're sort of, especially after COVID, over the hump in hospitals seeing acute telehealth as a worthwhile investment? I know, one of the biggest barriers, as Dr. Sturgeoner said, there's always many priorities happening at once. So it's always a matter of sort of breaking through that and bubbling up your needs. But in terms of convincing and having, teams react, what the heck is tele ICU or acute telehealth? Do you think we're over that hump?
I think that we're really making headway. I think we said that COVID not necessarily brought it to the forefront, but really was a catalyst. I think that people were starting to get to that point anyway. And then I think COVID just really reinforced that. There was so much need during that time. And so I think we've just been able to expand on that. And I think there's a lot more buy-in and a lot more support for all of the telehealth programs in Tele Icu now, but then prior to the pandemic.
Does the reality of today's volumes, they are going down. We were actually looking at pathology and COVID circumstantial and COVID cases. I think we lost a lot of human beings that had comorbidities, multiple comorbidities, and we have healthy populations. So again, like everything else, Tele ICU and telehealth has to reinvent itself. So that's why I think that Tele ICU can play a significant role through a portable platform, as Philips has to offer, to reach patients everywhere and anywhere, in LTAC, in SNFs, at home. Again, critical care sans frontier. We are not going to be only in the ICU.
Great. Anything else from the Dartmouth side?
Yep. I mean, I think it's really right. We have to think about critical care and acute telehealth in different ways. I think the importance of being flexible and ready to take on challenges is important. It's really a big lift to get going and to invest in a Tele ICU program. But once you have the resources and you have the people who understand how it works, you can use that knowledge to address any number of challenges your health system faces. So I still think that an initial hurdle is there, but I think that acceptance of the technology and approach is much more extensive than it was.
Great note to end on. I really want to thank all of our speakers, Dr. Sturgeoner, Lily, Dr. Ilescu, Julie Mills. Thank you so much. And of course, thank you, SCCM. That wraps up our session for today. So thank you, audience, for joining us, and enjoy the rest of the Congress.
Thank you.
Thank you.